Good evening, Chair and members of the HLAP board. I am Shamsa Ikram. As a finance manager, I will focus on the financial sustainability pressures currently affecting healthcare services across Hertfordshire and the strategic decisions required to ensure long-term system viability. At present, the system is experiencing a dual financial shock. On one hand, we continue to operate under austerity-driven funding constraints, and on the other, persistent inflationary pressures are significantly increasing the cost of delivering care. This combination has created a widening gap between available resources and growing service demand, placing considerable strain on both NHS and local authority funded services. In practical terms, this has led to increased operational cost across council run care homes, community health services, and preventive programs, while real terms funding has declined. This imbalance is affecting not only financial performance, but also service continuity, workforce stability, and quality of care. From a strategic perspective, this situation can be understood through resource dependency theory, which highlights how organizations reliant on constrained external funding are forced into difficult prioritization decisions. In this context, it is increasingly clear that it is no longer financially feasible to sustain all services at their current level or delivery model. Our financial analysis identifies three key pressure points. Firstly, rising staffing cost, particularly in care homes and community services, driven by high turnover, agency reliance, and recruitment challenges, which also impact continuity of care. Secondly, is it is increased cost per patient in community-based preventive services, largely due to inefficiencies and low uptake, meaning resources are not delivering proportional outcomes. Thirdly, inflation-driven increases in non-discretionary overheads such as utilities, transport, and clinical supplies, which are difficult to control without systemic change. If unaddressed, these pressures will lead to unsustainable deficits, reactive decision-making, service reductions, and potentially unplanned closures. This would not only compromise patient care, but also increase a long-term system cost through greater demand for acute services. In response, I propose a structured financial prioritization framework to support evidence-based and ethically informed decision-making. This frame categorizes services into three tiers: essential, adaptable, and then non-essential. Firstly, we will talk about essential services, including emergency care, acute pathways, and high-risk chronic disease management. These must be fully protected as they are critical to patient safety and system stability. Then let's talk about adaptable services, particularly in community and preventive care, should be redesigned rather than reduced. There is significant opportunity here to improve efficiency through digital delivery, group-based interventions, and integrated care pathways, such as virtual consultations or community-led programs that reduce cost per patient while maintaining access. Coming to non-essential or low-impact services should be critically reviewed and, where appropriate, consolidated or delivered in partnership with the voluntary and community sector, supporting a more sustainable system-wide approach. Alongside this, I strongly recommend adopting activity-based costing models. This would provide clearer visibility of resource allocation at service level, helping to identify inefficiencies, reduce waste, and ensuring funding is directed toward high-value activities. Improved financial transparency is essential for accountability and strategic planning. However, financial reform is not only a technical exercise, it also is a leadership challenge. And from a leadership perspective, applying the transformational leadership theory, it is essential that these changes are communicated with the clarity, transparency, and empathy. Staff must understand not only what is changing, but why it is necessary. This is critical for reducing resistance, maintaining morale, and sustaining engagement. Leaders must also actively involve frontline staff in service redesign, recognizing their expertise and insights. This participatory approach improves decision making and strengthens organizational resilience during periods of change. Importantly, financial decision making in healthcare also carries ethical implications. Prioritization must therefore be guided not only by efficiency, but also by equity, accessibility, and patient need, ensuring vulnerable populations are not disproportionately affected. In conclusion, financial sustainability in Hertfordshire's healthcare system can only be achieved through disciplined prioritization, service redesign, improved financial transparency, and strong, compassionate leadership. Without these measures, the system risks entering a cycle of reactive cost cutting that undermines both quality and equity of care. By taking a proactive and strategic approach, we can ensure that limited resources are used effectively to deliver maximum value for patients and communities. Thank you for listening to me. Oves will cover the next part.
Thank you, Shamsa. My name is Mohammad Awais Rathore, and I am Director of Operations. As Director of Operations, I will address the systemic inefficiencies and service delivery challenges currently affecting healthcare services across Hertfordshire. At present, the operational landscape is highly fragmented with duplication of services across council run care homes, NHS pathways, and voluntary sector provision. This fragmentation not only leads to inefficiencies and increased operation cost, but also results in delayed care and inconsistent patient experiences. Ultimately, it undermines the continuity and quality of care that patients receive. Adopting a system thinking approach. Healthcare should be understood as an interconnected network rather than a collection of isolated services. However, current breakdowns between service points, particularly during transitions of care, are contributed to poor coordination, reduced continuity, and significant operational waste. So these inefficiencies are not just structural, but they directly impact a patient outcomes and staff overload. So, a key operational challenge is the reduction in service capacity driven by workforce shortages and ongoing financial constraints. As a result, services are increasingly being rationed with longer waiting times, emergencies like, especially within preventive and community based care. This reactive model places additional pressure on acute services, further exacerbating system strain. So, in addition, there is a clear lack of integration between community services and hospital pathways. This disconnect often leads to avoidable hospital admissions where early intervention at a community level could have prevented escalation. So, consequently, hospitals are burdened with these cases that could be managed more efficiently elsewhere. So, to address these challenges, I propose the implementation of an integrated care model that aligns primary care, community services, and voluntary organizations into a more cohesive system. So, this approach will reduce duplication, enhance communication between services, and ultimately improve patient flow and also care continuity. So, secondly, we recommend the introduction of a digital first triage system by enabling non urgent cases to be assessed and managed remotely. This system can significantly reduce unnecessary face to face appointments, thereby freeing up clinical capacity for high risk and complex patients. So, in doing so, it also supports greater accessibility and responsiveness within the system. Thirdly, the main thing, the adoption of lean management principles will be essential in identifying and eliminating operational waste by streamlining processes and focusing on value added activities. So, healthcare services can improve efficiency while maintaining high standard of care. From a change management person, operation will require a structured and strategic approach. So, in conclusion, achieving operation system by these area. So, I will next give my colleague Aisha. So he will uh, process it later. Thank you.
Thank you, Wes, and good afternoon, Chair and members of the board. And I will be an HR manager. So, as an HR manager, I will focus on the workforce crisis currently impacting the healthcare delivery across Hertfordshire, and the strategic actions required to stabilize and sustain the workforce. And at present, we are facing significant and multifaceted challenges. There are high levels of staff turnover within the council run care homes, alongside persistent staffing shortages across voluntary and community health services. And these shortages are not isolated issues. They are systemic and have direct consequences for services continuity, staff well being, and ultimately patient safety. So, from an operational perspective, gaps in the staffing are leading to an increased reliance on temporary and agency workers. So, disrupting continuity of the care and increasing cost. At the same time, it's the remaining staffs are required to absorb additional workload, often beyond their capacity, which further worsens the stress and dissatisfaction. And to better understand the root cause of this crisis, we can apply Herzberg's motivation, that is, hygiene theory. This theory distinguishes between hygiene factors such as salary, working conditions, and organizational policies, and motivators, including recognition, career progression, and professional growth. So, in our current system, many hygiene factors are inadequate, while motivators are limited. As a result, the staffs are not only dissatisfied but also disengaged, leading to an increased attrition. In addition, burnout theory provides further insight into the current workforce challenges. Prolonged exposure to high workload demands, emotional strain, and insufficient organizational support leads to emotional exhaustion, dispersonalization, and reduced personal accomplishments. These symptoms are increasingly evident across healthcare services, particularly in the high pressure environments such as care homes, community care settings, etc. The impact of these workforce pressure is both immediate and long term. In the short term, reduced staffing levels are forcing service reduction, increasing waiting times, and placing patient care at risk. In the long term, we risk entering a cycle of attrition where overworked staff leave the system, further intensifying shortages and placing additional strain on those who remain. This cycle is not sustainable and requires urgent intervention. In response, I propose a comprehensive workforce stabilization strategy built on three key pillars like retention, development, and workforce optimization. Firstly, retention must be prioritized. And this includes implementing targeted initiatives such as competitive pay adjustments, particularly in high turnover areas, alongside more flexible working arrangements to support work life balance. Equally important is the introduction of structured well-being programs, including access to mental health support, stress management resources, and protected time for recovery. Retention is not solely about financial incentives, it's about creating an environment where staff feel valued and supported and able to sustain their roles over time. Secondly, we must invest in training and development pathways to build long term workforce capacity. This involves strengthening partnerships with universities, colleges, and training providers to create clear entry routes into healthcare role as well as progression pathways for existing staff. Apprenticeships, continuous professional development programs, and leadership training can all contribute to a more skilled, motivated, and future ready workforce. By doing so, we can shift from reactive recruitment to proactive workforce and planning. Thirdly, I recommend the introduction of a skill mix optimization model. And this approach ensures that tasks are allocated appropriately across multidisciplinary teams and enabling and supporting better patient outcomes. However, workforce strategies alone are not sufficient without effective leadership. From a leadership perspective, embedding servant leadership principles is critical. Servant leadership's emphasis supporting and empowerment of staff, actively listening to their concerns, and prioritizing their needs. In the current climate, this approach can help rebuild trust, improve morale, and strengthen engagement across the workforce. Leaders must also adopt a visible and inclusive approach, engaging directly with frontline staff to understand their experiences and involve them in decision making processes. This not only improves the quality of decisions but also fosters a sense of ownership and commitment to organizational goals. It is also important to recognize that workforce challenges are closely linked to broader system pressures, including financial constraints and increasing demand for services. In conclusion, the workforce crisis facing Hertfordshire's healthcare system represents a critical risk to service sustainability. Without immediate and strategic intervention, staffing shortages will continue to undermine care delivery, staff well being, and organizational performance. By prioritizing retention, investing in development, optimizing workforce models, and embedding compassionate leadership, we can begin to address this crisis in a meaningful and sustainable way. Thank you. Over to Naseem.
Thank you, Aisha. Myself, Naseem Abbas. My role is clinical director. As a clinical director, I will focus on clinical quality, patient safety, and associated risks. The reduction in both staffing and funding is now translating into measurable clinical risk, particularly in chronic disease management services such as diabetes care and smoking cessation. Using the Donabedian model, we can see how structural issues or staffing shortage are negatively affecting care process, ultimately leading to poorer patient outcomes. This is also increasing the risk of avoidable hospital admission due to weakened preventive services, placing additional pressure on acute NHS provision. Furthermore, reduced continuity of care is increasing the likelihood of clinical errors and understanding patient confidence. To mitigate these risks, we recommended a clinical prioritization framework based on a risk stratification. High risk patient must be prioritized, while lower risk cases can be managed through community or digital models. We can also propose strengthening clinical governance system to ensure continuous monitoring of quality and rapid response to emerging risks. Finally, integrating care pathways across services will improve continuity and reduce fragmentation, which is a most important part of clinical direction. Transformational leadership will be essential in driving these changes and fostering a culture of accountability and improvement. In conclusion, safeguarding clinical quality requires prioritizations, strong governance, and integrated care delivery. Thank you. I will now hand over to Hassan.
Sorry, your mic is off. Your mic is off, Hassan. Can you please turn it on? Hassan, your mic is off.
Uh, Sorry for the interruption. Uh, Thank you so much, Naseem. Uh, Good afternoon, chairs and members of the board. As patient choice lead, I will focus on three critical dimensions of the healthcare delivery. First one is patient trust, second one is the equitable access, and third one is meaningful engagement. A major systemic challenge currently facing healthcare services across Hertfordshire is the declining level of patient trust, which is directly impacting service utilization, particularly within preventive and community-based care pathways. This is not simply an operational issue; it is a behavioral and relational challenge that sits at the heart of the healthcare effectiveness. Drawing on established health behavior theory, particularly the health belief model, we understand that patients are more likely to engage with healthcare services When they perceive a clear benefit, feel confident in the system, and believe that the barriers to access are minimal. However, when trust is eroded, so these perceptions shift negatively, and patients may underestimate the benefits of care, overestimate the barriers, or disengage entirely from the services. So this pattern is particularly evident in key public health areas such as smoking cessation programs and diabetes management services, where we are seeing a concerning decline in uptake despite a rising prevalence of long-term conditions. So this disconnect highlights a critical issue like availability of services does not guarantee utilization. So there are several underlying barriers contributing to this decline. Firstly, ineffective communication remains a persistent challenge. Information is often delivered in ways that are not accessible, not culturally sensitive, or not tailored to diverse population needs. Secondly, there is a lack of awareness, particularly among vulnerable and underserved groups about the availability and benefits of services. Thirdly, and perhaps most importantly, the previous negative patient experiences, including long waiting times, perceived lack of empathy, or fragmented care pathways, have led to breakdown in the trust. Uh, from a system perspective, there is a effective gap between service design and patient reality. Services are often designed around organizational efficiency rather than patient experience, which ultimately undermines engagement. So, to address these challenges, I propose the implementation of a comprehensive patient engagement and trust restoration strategy that is grounded in evidence based practice and aligned with NHS patient centered care principles. So, firstly, we must prioritize core design services. So, this means actively involving patients, carers, and community representatives in shaping how services are delivered. So, co-production not only ensures that services are more responsive to patient needs, but also fosters a sense of ownership and trust. So, when patients feel heard and valued, so they're significantly more likely to engage. Secondly, we need to strengthen our communication strategies. So this goes beyond simply providing information. It requires delivering clear, consistent, and culturally appropriate messaging through multiple channels. For example, leveraging community networks, digital platforms, and primary care touchpoints that can help ensure the information reaches diverse population effectively. Most importantly, the communication should focus on building understanding of benefits, like addressing misconceptions and reducing perceived barriers. Thirdly, and most importantly, I would say I recommend implementing a continuous patient feedback systems rather than relying on periodic surveys. Services should opt real-time feedback mechanisms such as digital tools, patient forums, and community engagement sessions. So this will allow organizations to remain responsive, adaptive, and accountable, ensuring that patient voices directly inform service improvement. So, in addition, there is an opportunity to mitigate behavioral insights and personalized engagement approaches, such as targeted outreach for high risk groups, reminder systems, and health coaching models. So, these interventions can further support sustained engagement and improve health outcomes. From a leadership perspective, addressing this challenge requires a shift towards participatory and inclusive leadership models. So, leaders must move beyond top down decisions making and instead uh, foster a culture collaboration, transparency, and trust. So, this aligns with transformational and servant leadership principles, where the focus is on empowering patients and communities as active partners in care. Furthermore, rebuilding trust is not a short-term intervention. So it requires a consistent, visible commitment across all levels of the healthcare system. So every patient interaction becomes an opportunity to either strengthen or weaken trust. So in conclusion, without effectively addressing patient trust and engagement, even the most well-funded and clinically advanced services will remain underutilized, leading to poorer health outcomes and increased long-term system pressures. So by embedding co-production, improving communication, and creating responsive feedback systems, we can begin to rebuild trust and ensure that services that truly meets the needs of the population we serve. Thank you so much. So over to Rahman.
Hello. Thank you so much, Hassan. Good afternoon, Chair and member of the board. As the representative of Hertfordshire voluntary and community sector, I will focus on community-based healthcare provision, the role of the voluntary sector in prevention, and the growing challenge of health inequalities across the system. At present, the voluntary and community sector is under significant strain. We are experiencing reduced staffing capacity, unstable and often short-term funding arrangement, and a substantial increase in demand for preventive and sport based services. So these things including in such areas like smoking cessation programs, diabetes, self management, sports, and also including mental health community groups and social prescribing initiatives. So, furthermore, these services are often delivered at a relatively low cost but generate high long term value for both individuals and the wider healthcare system. So, the current resources concentrates are limiting their reach and effectiveness at a time when demand is actually increasing. From a public health perspective, this is particularly concerning when viewed through the lens of the social determinants of health. We know that factors such as like income, housing, education, employment, and social isolation significantly influence health outcomes. So, the voluntary sector plays a critical role in addressing these wider determinants by providing early intervention, community engagement, and holistic support that the formal healthcare system is often unable to deliver alone. So, however, due to current financial pressure, the capacity of these services to deliver early intervention is being weakened. As a result, preventable conditions are progressing further before support is accessed. So these things ultimately shift pressure back onto NHS acute and primary care services, increasing demand, cost, and system strain in the long term. So, in the other word, under investment is community and voluntary services is not reducing expenditure. It is displacing it into more expensive areas of care later in the pathway. If we look at this systematically, it becomes clear that the voluntary sector is not an optional add-on but a fundamental part of a sustainable healthcare model. So these things act like as the bridge between clinical services and everyday community support, particularly for vulnerable and hard to reach populations. To address these challenges, I recommend a three-part strategic approach. Firstly, we need to develop a sustainable community partnership funding model. This model move away from short-term fragmented grant funding toward longer-term communizing arrangement. By providing financial stability, voluntary organization can plan more effectively, retain skilled staff, and invest in services development rather than the constantly managing funding uncertainty. This would also enable better alignment between NHS, local authority, and voluntary sector priorities, ensuring that resources are directed toward areas of greatest need and impact. So the second thing is that I recommend expanding volunteer recruitment, retention, and training programs. Like volunteer are a vital part of the community workforce, but these require structured support to be effective. But investing in training, supervision, and clear role of development pathway, we can strengthen workforce capacity while also improving services quality and consistency. So that this approach is also create wider social values as a volunteering can improve community engagement, social inclusion, and individual well-being, particularly among retired individuals, students, and those seeking flexible work opportunities. Thirdly, this is need to formally integrate voluntary sector services into NHS care pathway. At present, there is a often fragmentation between clinical services and community provision, leading to duplication, gaps in care, and poor communication. By embedding voluntary services within formal referral pathway, for example, through social prescribing, link worker or integrated care both, we can improve continuity of care, ensure patients are supported beyond clinical settings, and reduce unnecessary pressure on GP practice and hospitals. From a leadership perspective, enabling this level of cross sector working requires a shift toward collaborative leadership theory. This approach emphasizing shared responsibility, trust building, and joint decision making across organizational boundaries. So, in practice, this means moving away from siloed working and toward a more integrated system where NHS, local authority, and voluntary sector patrons are jointly accountable for outcomes, not just individual service delivery targets. And strengthen the voluntary and community sector is essential for building a prevention focused, equitable, and sustainable healthcare system. Without investment in community based provision, the system will continue to experience rising demand in acute service and widening health inequalities. By securing sustainable funding, building workforce capacity, and integrating services more effectively into NHS pathway, we can ensure that the community care become a central pillar of healthcare delivery rather than a undersupported complement. Thank you for listening.
This was for the today's meeting. And thank you. I will thank all of my colleagues, Ovais, Aisha, Naseem, Hassan, and Rahman for joining me. And so this is the end of meeting. Thank you to the audience for listening us.
Thank you. Thank you.
Thank you,
Thank
thank
you.
you, thank you, thank you. Bye.
Thank you.
Okay.